All right, we're a little bit behind schedule, but we'll try to move through. This one is on examining psychiatry and mental disorders by medicine, science, and the Bible. Again, please remember to be like the Bereans. Some definitions. Psychiatry is a branch of medicine that deals with mental, emotional, or behavioral disorders. Mental is of or relating to the mind, intellect, or spirit. A disorder is to disturb the order, the regular or normal functions of something, out of order, abnormal. Illness, a condition of being unhealthy in your body or mind, a specific condition that prevents your body or mind from working normally, a sickness or disease. Now, originally, illness was understood to be something of the physical body, the physiology of the body, flesh, liquid, bone, blood, fluid, something tangible. And we'll get through it later to see where the origins of psychiatry come from. But they were trying to take the authority of the scripture away on issues of the soul of man and tried to medicalize it. And that's what they have done then. They changed the definition of illness to include just something that's out of order, something that is preventing normal activity. And there's maybe a little bit of legitimacy there, but we need to have carefulness with that and remember that. Also, when they talk about the disorder, usually it has to do with, it's more to do with how it's affecting other people and their discomfort than it is the person. That maybe doesn't make quite as much sense as it should. But in other words, usually the person that's so-called struggling with what gets labeled a disorder, they don't always think they have a problem. A lot of times it's more the people living around them get upset, get tired of it. They want to try to get this thing changed because it's making their life inconvenient or making their life difficult. Again, keep that in mind as you think about the body working together with the weak brother and with problems that come up. Basic points of psychiatry: medicalization or doctoring of the soul, mental struggles or brain illnesses, malfunction of the brain as an organ, usually seen as being for the rest of life. They understand it to be caused by chemical imbalance, and they usually see it as following family lines or genetic. And again, think about what I said about the Bible's teaching. You train up a child in the way he should go, and when he's old, he will not depart. If you think about that biblical foundation as you think about genetic lines with mental disorders, it usually fits. That biblical principle is usually a very clear connecting link. And as we look at the roots of psychiatry, the philosophy of psychiatry, and long-term outcome studies, what works and what doesn't, you'll see that what I'm saying here makes sense. Disclaimers and cautions. We are not medical professionals, nor are we endeavoring to give medical advice. It is always potentially dangerous to start taking psychoactive drugs and potentially even more dangerous to stop taking them. Some people ask, what is psychoactive? How many here drink coffee? Okay? How many believe that if you drank too much coffee for too long, eventually it could cause problems? And how many feel that, depending what the issue is, it would be wise to stop taking it? Huh? Not quite so many sure there. Okay. But you might get to that point someday. And I'm at the point where I have to watch how much I drink. It depends. Okay. Caffeine is a psychoactive drug. I took some this morning. I also took some ibuprofen and some Mucinex. That's also a psychoactive drug. We're not saying taking drugs is a sin. I would like to make that very clear. If we have tremendous physical pain and we go to the emergency room, they will give us our narcotic, and we're okay with that. But we also would be very concerned to try to take that narcotic continually long term, because we know it would have severe end consequences. I'd just like to point that out. The other thing is, when we have our loved ones on deathbed, we're usually okay with hospice coming in and giving them morphine. Because a lot of times the pain can be so strong, they maybe can't think clearly. And so you give them some morphine to help dull the pain so they can think clearly. But I also know that there's this wrestling within the thought that you don't like to have them on so much morphine that when they come to that moment of death, that their mind is so drugged that they can't think. That is a discussion that we all, or most of us, understand that dilemma. Morphine is a psychoactive drug. Psychoactive means anything that is active on the psycho, on the mind. I'd like to put that out as a foundation for what I want to share today. We're not saying it's sin to take the drugs. What we'd like to show is from medicine and science what the drugs are actually designed to do, what they are. They are not medications like some of the medications you get when you go for health problems. They are not antipsychotics or antidepressants like an antibiotic. It's not anti in that it's attacking the pathology of something, because they don't have any pathology to go by. You'll find that as we go through. What they do know is they're going by the clinical evidence or the anecdotal evidence. That's what they're going by. They give the person who's struggling the drug. It knocks down the target symptoms. Therefore, it seems like it's working on a pathology. The problem is they're starting looking through the glasses of it being a biological problem. And we'll see where that comes from as we go through. So what we're trying to do is give an awareness of what the drug is, what it's designed to do, how it affects the brain, and show you some other options that are shown by the secular world to work actually better, way better than drugs. And I'll have conclusive evidence as we go through to show that. And then you are better informed to make an informed decision when you face a situation. Is this drug going to be beneficial? Is the effect of the drug going to be beneficial to affect my struggle? And you're aware of what long-term effect is going to be, so you have a carefulness there. And so that's our goal, not to try to say you should never take them, and specifically if you are taking them, to never, never, never come off. That's my next one here. Never stop taking psychoactive drugs without understanding their cause and effect and without a medical professional. One of the arguments that people use is if people quit taking their meds, they will commit suicide. Dr. Peter Breggin has been doing this kind of work for over 35 years. In all of his professional life, he has been helping people understand what the drugs are. He's been helping them come off of the drugs, and he has said that is the key argument, and he has never had one of his patients commit suicide. It's because they don't understand how the drug works in the brain, what happens in the brain change when you're on the drug, and then how to safely come off. And I'll just say a little bit here in the beginning. The drug goes in, it automatically is designed to target a specific normal brain functioning chemically. It interferes and alters that functioning, and then the brain is designed by God to heal itself. So the brain realizes something is out of order, or it has a chemical imbalance that's caused by the drug, and the brain starts going through literal tissue change. And that has been proven through research in the laboratory. That is a fact of research. They know that. They know that's what the drug does to the brain, and they know that's how the brain responds to it. So you have literal tissue change to try to, it's what they call compensatory reaction. It's reacting to the problem of the artificial intrusion of the drug into the brain, and it's reacting to that, and it's trying to compensate for it, make up for it. Just like if you have a vein taken out of your leg, the body will eventually make other blood passageways to keep the blood flowing. The same way works in the brain. The chemical artificially stops a certain function in the brain, and I'll show you that as we go through, and the brain starts to change the tissue in the brain physically so that it get back as much as close to possible as normal chemical flow of that specific chemical. This is all documented in research. There's no proof otherwise. This is the way it works. So when you come off of the drug, if you just go on a low dose, that problem isn't near as severe. And then if you quit and come off of it rapidly, it's not so severe. But if you're on a higher dose and you try to stop automatically, when you're on antidepressant, literally in the beginning when these things came out, they were not called antidepressants, and antipsychotics. They were called by their literal chemical functioning or their literal chemical effect. It was either stimulants or tranquilizers. Stimulants or tranquilizers. That's the two categories that they had. And as time went on, they wanted to become more like medicine in the eyes of the society. So on the same drugs that they were using, they didn't have new drugs or new formulas or anything. What they used to call stimulants, they now called an antidepressant. And what they used to call tranquilizers, they now called an antipsychotic. That is in the actual literature. They have photocopies of the advertisements, before and after, same drug. They were doing that to make it more palatable and to take away the stigma and to try to make it sound more like medicine. In reality, antipsychotics actually cause the brain, if you have long-term use of an antipsychotic, 6 months or longer, it causes enough tissue change in the brain, as what it's taken at a therapeutic dose, that the brain starts to shut down. The antipsychotic will shut down roughly 70% of the transmitters on every neuron so that it doesn't produce as much dopamine. And so the brain tries to make up for that by creating tissue change. And one of those things it does is it grows new transmitters. And they find those in autopsies. And they wonder why. And so they thought it's because of schizophrenia. That's what's causing the extra transmitters. But then they checked schizophrenic patients that had no antipsychotics, and their transmitters are the same as normal people without schizophrenia. So they concluded that the drug is causing the brain to create more transmitters. And so it's trying to make more transmitters to create more flow. The other thing it does, the brain takes what's left over of the receptors that are still functioning, and it thins them out to become extra sensitive. And once that happens, the person becomes super sensitive to relapse into future psychosis. It's what they call chronic cycling. They become extra. It also, another term is called tardive psychosis, meaning it's coming later on. Anything that's tardive is later on that's being caused by the drug. Another term is iatrogenic, that's caused by the drug. If tardive dyskinesia is another term, that's a very common term in the mental world. Tardive dyskinesia means a person has facial and tongue movements that are uncontrollable, that is a direct result of irreparable brain damage caused by the drug. That's all in antipsychotics. Antipsychotics are the worst, but the antidepressants also cause problems. So with an antipsychotic, it's putting the brake on to slow down the dopamine system. The brain is trying to react and it puts the gas pedal on. And as it's going like that, now it's trying to function with this tension, the brake and the gas pedal. The drug has the brake on and the brain has the gas pedal on. All of a sudden, they stop the antipsychotic cold turkey. What happens? You have a runaway train. You hit that curve, you're gone. Does it make make you wonder why people commit suicide? There's no wonder. That's why it works. When they take an antidepressant, it is a stimulant. And so now the antidepressant is putting the gas pedal on, the brain is putting the brake on. And again, it's under this tension continually because it has this artificial intrusion of the drug in the brain. If they quit that cold turkey, after on that long-term and high dosage, all of a sudden it's like, and the brain just stops. It just can't go. That is why we need to realize what it does and how it works. And if you realize that, you went on it slow, the brain made a slow, gradual change. And what they say, I have books here, that is what we need to go by to start understanding the safe way. You go to the professionals, you go to your doctor, you work with a professional. Here it says without medical professional help. And you do a gradual taper very slow, and you let the brain start to compensate back as the drug effect goes away. And the rule of thumb that Peter Bregan says is a taper of 1 month per year per drug use. So if a person is on 3 drugs for 3 years, that's 9 months of taper. And yet I've gone with people to the psychiatrist, and he said, yeah, if that's what you want to do, that's fine. But actually, you don't need a taper. You can just stop it. And I told him, I said, they don't understand what that's going to do, or else they know that's going to prove that they're right, and they'll come back to you automatically. Because of their inherent tendency to be addictive, and addictive here is the idea that it's not so much like cocaine where you want more and more and more, except the ones like Ritalin and some of those are. I think it's what they're called a class 2 action. I think it's a class 2 drug, I think, by the DEA. And it's actually, the Ritalin is actually sold in the black market to college students. Excuse me. But by addictive, it means that once you start taking it, if you start to come off, there are withdrawal symptoms. And people usually think that this problem that they're experiencing by coming off is related to the, quote, disease. That's usually what the doctor says. Peter Bregan says that if that's what you think it is, the way to test that is, if you're in the slow taper, and all of a sudden you start experiencing these weird physical symptoms, and you think it's part of the disease, just go back on the last dosage the last level you came down from, and usually that symptoms will go away. And if it goes away, that proves to you that it was a result of the withdrawal symptom. And I've experienced that in working with people. That's what happens. Come down part way, they start experiencing that, you just go back a little bit, and it goes away. And then they realize, oh, the drug is causing it. Okay, so let's go for it. And we'll face the battle. It's an extreme storm to go through withdrawal from some of these drugs. It is extremely excruciating. Now, some people don't have that. They take a little bit now and a little bit again, and they don't have that same thing. But that is the potential when you get on them. There's actually more people die in America from taking psychotropic drugs than from taking illegal drugs. That is what Alan Francis says. He is a very well-respected authority in the psychiatric community. So because of their inherent tendency to be addictive, always research the drug effect and exhaust all other options before agreeing to start taking them, and then only for short term if you need to. If the drug effect might be beneficial, try to make sure if there's anything else you can do first, because they are potentially very addictive. But then if you do need to take them, the encouragement is, and this is what all long-term research literature says, only take it for a short time to stabilize whatever the extreme problem is, and then start coming back off again. Try not to take it for 6 months or a year. If you have to take it for a month or two, they're saying, if you need to do that, go ahead. But then try to come back off and deal with it from the mind. And we'll get through that. Scripture to filter all content. 2 Peter 1:3, according as the divine power hath given to us all things that pertain unto life and godliness, through the knowledge of him that hath called us to glory and virtue. Proverbs 4:23, keep your heart with all diligence. And what I would like to suggest is these scriptures are very, very important. We look at the long-term outcome studies. We look at what's working presently in the world. They're showing us that the issues are of the mind, not the brain, in most cases. And the issues are of the heart, an emotional and spiritual struggle, in most cases. And the Bible talks about all of this. Out of the abundance of the heart, the mouth speaks, Matthew 12:34. For out of the heart come forth all these evil things. And he has a whole list there. And when you think about it, the things that the psychiatrist is trying to medicate for, a lot of it falls into these categories. There in Mark 7:21-23. More scripture, 2 Timothy 3:16. All scripture is given by inspiration of God, profitable for doctrine, reproof, correction, for instruction in righteousness. Another thing we'll find as we go through the literature is that mental struggles usually are a problem of an undisciplined mind that has begun as a child. They didn't learn to discipline their mind, and they continue to let that mind just run free, just like whatever, with no discipline. That's why it's so important as we as parents know the hearts of our children, have the hearts of our children. We interact with them. We help them learn how to discipline their mind. We encourage them to talk about what they're thinking, what they're struggling with. We help them to find God's answers, to think properly, think what's good, of good report, right, all of that, what it tells us. For the word of God is quick and powerful, sharper than a two-edged sword. At the end there it says, and a discerner of the thoughts and intents of the heart. And this is one thing that I say proves that heart is the mind, the will, and emotions. Emotions just feel. The mind and the will have thoughts and intents. So you have something happen, and then you start to feel a certain way, and then you start to have an agenda to decide how to respond to it. And that's where you have thoughts and intents. Excuse me. 2 Corinthians 10:5, casting down imaginations and every high thing that exalts itself against the knowledge of God, and bringing into captivity every thought to the obedience of Christ. Romans 12:2, and be not conformed to this world, but be ye transformed by the renewing of your mind, that you may prove what is that good and acceptable and perfect will of God. And this is where in Finland and Lapland, they have a whole region that they're working on things from in a secular way, saying it's of the mind, not the brain. It's in faulty thought patterns, not in some brain malfunction. And yet they're doing it from a secular perspective, and the research they're looking at is acute psychosis, and that is the predecessor of schizophrenia. To be diagnosed schizophrenic, you have to have a first episode psychotic event and ongoing psychotic symptoms for up to 6 months. But over there, they can get those psychotic symptoms taken away before 6 months are up. They used to have one of the highest rates of schizophrenia in all of Europe, and now they have slashed that problem by 90%. They can get most of their patients recovered from their psychotic problems before 6 months duration. And the long-term outcome is they are able to have, in a 5-year period, first of all, they don't put them in antipsychotic for up to 3 weeks. If they have trouble sleeping, they'll put them on some sort of benzodiazepine or anti-anxiety pill to sort of help them relax and sleep, but only for 2 to 3 days. That's it. And then they take them back off. Because they say they want them to have a clear mind to sort through their psychosis. To us, that sounds strange. What they mean is they don't want them to have the drug effect in the brain to sort through the psychosis. By doing so, they wait until 3 weeks. If there's no positive change, they will put them on an antipsychotic to target the symptom, to knock it down, to help stabilize, and then try to take them back off. By so doing, they only need to put 1/3 of all first episode acute psychotic patients on an antipsychotic. And when I talk about acute psychotic, we're talking someone that's completely lost touch with the world. They aren't making sense. They're talking nonsense. Some of them might be crawling on their hands and knees. I mean, we're talking extreme mental breakdown here. And they're able to go in there and sit down with them in a careful, caring, loving, secure environment as a whole family, because they say that problem comes from the negative response to negative stress in their environment. And so we're going to figure out what this negative stress is, and we're going to try to figure out how the negative response was, and we're going to try to help them diminish the stress, give them care, time, patience, so they can recover, and help them learn a better way to respond to the stress in the future. And they say all psychosis comes out of relationships. So doing, they're able to have only 1/3 of their patients go on an antipsychotic. 2/3 they can help sort through that psychosis without any antipsychotic. And the end result is within 5 years, they have 80 to 90% of all first episode acute psychotic patients completely recovered. No drugs, no psychotic symptoms. They're living normally in society. They're living with a family. They're holding a job or going to school. Completely recovered. In America, we're told that psychosis or mental struggles are a disease that's lifelong. And yet they're showing us that you can have complete recovery within a 5-year period. And what we'll find is, before drugs, they showed the same thing. And even after drugs came on, when they did a study of poor countries versus rich countries, the poor countries were having those same results. And the reason is because they had strong communities, strong families, and they used drugs very, very minimally and for short duration. And they had about the same response, about 85% recovery within 2 to 5 years. And so that shows that what the Bible is saying is true. Mental disorders described as the same as a pancreatic disorder. Remember that. I'll show you things later that shows that this does not make sense. Understood as a malfunction of the brain. Got the wrong one there, sorry. Usually believed to be lifelong, understood as not being competent or normal, diagnosed as abnormal behavior. Long-term outcome studies, I went through some of this. Mind problems versus brain, faulty thought patterns, one-time crisis versus long-term. Drugs knock down the target symptoms, but drugs actually, in the long-term studies, show that the drugs tend to precipitate chronicity, meaning the precipitate, like rain, it's something that's happening. It's causing chronicity, meaning an ongoing chronic problem. All long-term outcome studies show that drugs tend to precipitate chronicity. The greater percentage of schizophrenia patients have always recovered within 2 to 5 years. The greater percentage, not all, the greater percentage. In all long-term outcome studies, when treated from a non-drug or delayed drug approach. Mental struggles used to look at as being insane or mad. Now it's looked at as being emotional, nervous, or mental breakdowns. It used to be extreme cases only. Now you have normal life struggles becoming abnormal mental disorders. And you used to have 70% of all extreme cases recovered within 12 to 18 months with no drugs. And today you have deviance, which is sin, becoming medicalized, becoming a disease. 20% of our society today are taking psychoactive drugs regularly. Now we're going to look at some quotes. These are quotes from psychiatrists that were developing the philosophy of psychiatry. This is the foundation of what is determining our problems today. Remember, this is a different religion, and you'll see by their quotes, it is a religion. In short, the nature of the hallucinations of Jesus, as they are described in the Orthodox Gospels, permits us to conclude that the founder of the Christian religion was afflicted with religious paranoia. Charles Benet Sangl in The Madness of Jesus in 1910. Everything we know about him, Jesus, conforms so perfectly to the clinical picture of paranoia that it is hardly conceivable that people can even question the accuracy of the diagnosis, by the American psychiatrist William Hirsch in 1912. Another quote, one may disagree with Schweitzer. He takes for granted that the failure of Jesus to develop ideas of injury and persecution rules out the possibility of a paranoid psychosis. This is not necessarily true. Some paranoids manifest ideas of grandeur almost entirely. Written by psychiatrist Winfried Overholser in his foreword to Schweitzer's book, The Psychiatric Study of Jesus. William Sargent, British psychiatrist. Jesus Christ might simply have returned to his carpentry following the use of modern psychiatric treatments. In other words, what he's saying is, everything that he did outside of his normal work, his ministry, his preaching, all of that stuff was a result of paranoia, result of a mental problem, a mental disorder. And if only they could have used psychiatric drugs on him, he wouldn't have had that problem. And he could have just gone back and been a carpenter, which is what he should have done. John Rawlings Rees, British psychiatrist, we have made a useful attack upon a number of professions. The two easiest of them naturally are the teaching profession and the church. The two most difficult are law and medicine. Spoken at the Strategic Planning for Mental Health in 1940. More quotes. As long as psychiatric problems were those of the soul, only the clergy and philosophers could be professionally concerned with such problems. So you see, they recognize it used to be that way. but they're trying to change that. This is in the history of psychiatry. We have swallowed all manner of poisonous certainties fed us by our parents, our Sunday and day school teachers, our politicians, our priests, our newspapers, and others with a vested interest in controlling us. See that? Controlling us. They thought that that's what's happening with religion. The inevitable results are frustration, inferiority, and neurosis. G. Brock Chisholm, psychiatrist in 1945. He's the co-founder of the World Federation for Mental Health. More quotes. The race will not be saved unless it is freed from its confused and distorted emotional and mental functioning. The reinterpretation and eventually eradication of the concept of right and wrong, which has been the basis of child training, the substitution of intelligent and rational thinking for faith, are the belated objectives of practically all psychotherapy. The fact is that most psychiatrists and psychologists have escaped from these moral chains and are able to observe and think freely. If the race is to be freed from the crippling burden of good and evil, it must be psychiatrists who take the original responsibility. Psychiatry must now decide what it is to be the immediate future of the human race. No one else can. Written again by G. Brock Chisholm, the co-founder of the World Federation for Mental Health. Today in the DSM, I have here the newest manual that the psychiatry industry uses to determine mental disorders. This is the DSM-5. And I also have a Christian book that is defining those same problems and trying to give a biblical observation of it. This is The Christian's Guide to Psychological Terms by Marshall and Mary Eicher. And it lists all the current mental disorders in here describing what the DSM is saying. And I got this out of this Christian's Guide. Religion is seen as a disorder, according to the DSM. A system of beliefs and practices centered around obeisance to an object or being which is believed to have power to affect the life of the believer. Psychologists identify two types of religion. One is cultural, the superficial conformity to an ethnic religious heritage. In other words, that which is the accepted norm is this cultural, and that's non-guilt inducing. The other is personal, arising from deeply held beliefs, and that is guilt inducing. Personal religion arises from guilt, fear, and a need to give life meaning. It produces three groups of responses. Reverential awe, and they're saying this is a problem. This is neurotic. The problem of the mind, it's abnormal. Reverential awe, motivation to good works, restraint and repression of unacceptable actions. It affects the whole person. All of personality is under influence of religion in this personal category. It accentuates inner conflict between the ideal and the reality, resulting in heightened fear and guilt, causing imposed morality. That's a concept that's very critical to remember. In psychiatry and psychology, they talk about imposed morality. And they think, therefore, when we try to teach our children right and wrong, that is imposed morality. Remember what we read earlier about the trying to destroy the right and wrong? That was their goal. That's what they were trying to do. They were trying to create what they understood as they were the authorities, and that religion is neurotic. In the U.S., 1/3 to 1/2 of psychologists and psychiatrists are atheists or agnostics. Here are some. Johann Christian Riehl, he's coined the term psychiatry in 1808. He argued that psychiatry be developed as a discipline in its own right, having its own trained practitioners. That's where this whole theory traces back to, about outside of the church professional help. It's a discipline. It's separate. It all traces back to here. Philippe Pinel, a very well-known reformer of psychiatry, he developed moral therapy, which actually was sort of trying to reform the old ways of treating the insane. He had the insane taken out of chains, shackles, and dungeons. Here you have Franz Joseph Gall. He developed the theory of phrenology. He established psychology as a science. He developed evolutionist theories, anthropology and sociology. he developed the naturalistic study of man. Phrenology was something that he decided, and I'll show you a picture in the next one, where he mapped out the skull, and he thought that you could feel the bumps on the skull to determine what a person's problem was. This is where some of the ideas of the naturalistic study of man, that it's biological instead of the soul. Phrenology, that's one of the diagrams of how they mapped out the skull. This here fellow was a little more modern than the other fellow. He's one of the pioneers of moral therapy, but he promoted the theory of phrenology and taught a naturalistic view. And so he sort of revived this idea of phrenology and naturalistic view. It had sort of died out, but he's reviving it. He believed that man is all material and not spiritual. And when you get into science and you start studying the human body, that's what science does. All science is built on evolutionary concepts out in the world, and so they have diminished human beings to everything material, and they have taken the spiritual out. This is also a very interesting fellow. He's an Italian psychiatrist. He was from the 1900s, one of the most influential Italian psychiatrists. He was a principal proponent of the Law 180, getting all Italian mental hospitals abolished or closed. And he actually got that passed, and they got the people that were in, who were chained and seen as being completely insane and violent and all that. They actually got them, they showed you could get them back into society. There were struggles, of course, but it could be done from a secular view. Benjamin Rush is known as the father of American psychiatry. He believed that insanity came from disappointed love, excessive drinking, religious fervor, lead poisoning, or measles. The retreat at York. This is of interest and value to consider, because back in 1796, the Quakers, before that, they were disheartened by their own people being sent to the insane asylums and how they were treated. They were appalled at the lack of humane treatment, because they understood back in those times that reason is what separated man from animal. And when a person had a breakdown or went insane, they lost their reason. Therefore, they believed they were now like animals, so they would treat them like animals. In 1796, the Quakers developed their own place called the Retreat at York as a faith-based alternative. They pioneered humane treatment and moral therapy, where when someone had a breakdown, they would go there. It was a calm environment. It was out in the country. They had people there just being kind to the struggling. They would treat them with respect as being created in the image of God, fellow human beings, but struggling human beings. And it still operates today. A 100-bed hospital is still operating today with no locked doors and no restraints for severely troubled people. Thomas Kirkbride was from America. He was a Quaker physician. He brought those ideas over to America and got the first hospital. It was a branch that came off of the Philadelphia hospital or the Pennsylvania hospital, and they built that'll be the next slide. He pioneered the Kirkbride plan, reforming medical care of the insane in America. He believed mentally ill could be cured, and after his wife died, he actually married a former patient. I call that practicing what you preach. You follow what I mean? He so believed in what he was doing of reforming and helping people recover that he actually married a former patient who was recovered after his first wife died. This is the Institute of Pennsylvania Hospital, the one that was developed by the Quakers, opened in 1841. It was developed and operated by Quakers, serene country setting, functioned using moral therapy. So that's a part of our history that we don't know. But that was done before everything became as it is today. That it worked. They would have caring facilities for the extremely mentally challenged people to go to. And a lot of the people would actually recover without medication. This here person is a very important part of our history in America. She was an activist. She went around to the insane asylums and saw the horrible treatment, and she started being an activist and petitioning the government to make changes. And she started getting them to put all kinds of struggling people, including those with dementia, those with Alzheimer's, Parkinson's, those who had syphilis, and those who, like drunkards, putting all those people into forcing the Quakers to take them in as well. And all of a sudden, it looked like the program isn't working because those people weren't recovering. So now your percentage of recovery went way down because they were putting people in that can't recover. You can't recover from dementia and Parkinson's. It's an actual brain problem. And so when I'm talking about the difference between brain and mind and brain problems versus mind problems, things like seizures, Parkinson's, Alzheimer's, dementia, those type of things are malfunctions of the brain. Some of those can be brought on by a spiritual struggle, but not necessarily. But what they're showing is all these other disorders actually were able to be helped, the majority of them, without any medical intervention. So that's important. M.L. Kreplin, he was a very well-known psychiatrist. He's the father of modern scientific psychiatry. Believed the chief origins were biological and genetic. Founder of psychopharmacology. I don't have all his credentials. I should. He's a current psychiatrist, and he has a lot of credentials behind him. He's not just a private psychiatrist in his own little practice. This is a very high up. He's been involved in all kinds of research and all kinds of literature, and I think he's a professor. And he wrote this in 2011 on Psychiatric Times. I get the Psychiatric Times newsletter so that I can stay up to date with what's being talked about within the profession or within the discipline. And I got this came to me, and I said, wow, this is important. I'm going to print this off. He said, until recently, the definitive diagnosis for Alzheimer's disease or arteriosclerotic dementia required a post-mortem pathological examination. Now, this is one who used to be considered, this problem used to be considered a disorder until they found the pathology. Once they found the pathology, it was now a disease because they can test and determine through biological factors that it's a disease. And once that happened, it was no longer called a disorder, but now it was given the disease name. The man's last name that discovered it was Alzheimer. And there you have again, so bipolar disorder, all the other disorders, by their very name, they're not a disease. They haven't found the pathology for it. And here he says, despite the diligent search for biomarkers for the so-called functional mental disorders, biomarkers means something you can biologically look for and find and test for to determine the pathology of the problem as being an actual illness. He's saying, despite the search for the past 100 years, nothing specific has emerged. Some years ago, there was excitement about biological tests in affective disorders, most reviewed at this symposium. To my knowledge, none of the foregoing tests are presently used in routine practice. There simply are insufficient data on specificity and sensitivity of these laboratory markers. That was on Psychiatry Times, 2011. Thomas Insel is the current director of the NIMH. NIMH is the National Institute of Mental Health. That is the top government position in our country overseeing everything to do with mental health. So this man is the top man in our country for everything regarding mental health. He's the current director since 2002. He's a psychiatrist and a neuroscientist, born in Dayton, Ohio. Here's what he wrote in April 29, 2013 on the NIMH website on his blog. The goal of this new manual, as with all previous editions, talking about this DSM that they were coming out with. They had changed some of the definitions, some of the disorders, put some new ones in, taken some out, tried to make this more accurate. That's the idea with a new version, correct? You try to make it more accurate, more conclusive. He says, While the DSM has been described as a Bible for the field, it is at best a dictionary creating a set of labels and defining each. The strength of each of the editions of the DSM has been reliability, meaning it's reliable in that each edition has ensured that clinicians use the same terms in the same ways. The weakness is its lack of validity. Okay, anybody who wants to say that psychiatry is valid, this is the top man in our country on all things to do with mental health. And he's saying the DSM, does not have validity. Its lack of validity. Unlike our definitions as ischemic heart disease, and we have a doctor in the back who can explain that if at some point if you want to ask him. But the idea is that it's actual. It's real. It can be tested for. Heart disease, lymphoma, or AIDS, the DSM diagnoses are based on a consensus by ungodly men determining the standard of normal and abnormal. Okay? It's a consensus about clusters of clinical symptoms of behavior. I put that in there, but that's what this means. Not any objective laboratory measure. Not any objective laboratory measure. In the rest of medicine, this would be equivalent to creating diagnostic systems based on the nature of chest pain. What kind of chest pain do you have? Okay, now we're going to decide how to diagnose you and how to treat you. Or the quality of your fever. What's it feel like? How's it acting? Now we're going to decide how to diagnose you and how to treat you. He says, indeed, symptom-based diagnosis, once common in other areas of medicine, has been largely replaced in the past half century, as we have understood that symptoms alone rarely indicate the best choice of treatment. That is the top man in our country talking about psychiatry and the way they figure out what's wrong with people. And when this was stated, the NIMH took a direct step away from psychiatry and away from the DSM, and they said, we are no longer going to see that as valid. We are going to start creating our own studies and come up with our own standard to determine what is accurate. And we're going to do it scientifically, and they said it's going to take us 10 years. In the meantime, keep using the DSM, because that's all we have to use. But we're going to find something that is accurate. That's not valid, but we're going to find something that's accurate. We're going to work on it. But they're still seeing it as being biological because they see man as being all material, all naturalistic, no heart. This is one of the newest disorders that came out. ODD, oppositional defiant disorder. That's in the new DSM. A habitually rebellious, stubborn, antagonistic, and insubordinate response to those who are in authority. This behavior must have been manifested for at least 6 months. The individual must display at least 4 of the following characteristics: uncontrolled anger, disobedience of rules, resistance to following directions, testing boundaries frequently, responding more often with verbal aggression than physical force, annoying others intentionally, irritation, frustration, unwillingness to compromise or yield to authority, argumentative, not accepting responsibility for his behavior and mistakes, blame shifting, resentfulness, seeking revenge. And it usually begins around age 8 and increases with age. Okay, that's the response I usually get. But here's what I say. The reason you respond that way is because on this issue, you are still standing squarely on God's word as the authority. And you're saying that's crazy. Now here's the point. Psychiatry has used the same criteria to define all the rest of the disorders as this one. And if you don't see it, within several years, you will have moved off of the Bible as the authority. And you'll see this literally from their point of view that they're correct. And you'll have a child who is rebellious, who's not listening. You say, that must be true. The Bible must not be correct. This is an exception to the rule. Okay, do you see the seriousness of this whole thing? You know, it didn't just start as some actual science. It didn't start that way. It's usually demonstrated at home, not necessarily at school. They see their response as a reasonable response to the unreasonable demands of those in authority. There's 3 severity levels. Mild, meaning just maybe at home. 2, meaning maybe at home and school. 3, meaning it has the severe, is if they have 3 areas where they're acting this way. And I didn't have time to put more disorders in there. You have ADHD, ADD, OCD, MDD, bipolar disorder. You have social anxiety disorder. And here's one on social anxiety disorder. And by doing some of my research, I've listened to the secular people talk. I've not been listening to the critics to do my research. When social anxiety disorder used to be just considered shyness. And when Paxil came on the market, it was an SSRI, a selective serotonin reuptake inhibitor, and the market was flooded with SSRIs by the time Paxil came on the market. And they wanted to sell their product. In order to sell your product, you have to find a market or make one. So the market was already flooded with antidepressants. So they found a group of advertisers who went about creating real slick advertising, putting it in big cities on bus stops, and I don't know where all they put it, but they put it around so that the public would start seeing this everywhere. Start talking about, do you get nervous when you're in a group of people? Or, all these little phrases about what defines shyness. And they would say, maybe you have social anxiety disorder. Do you feel this way? Maybe you have social anxiety disorder. Do you have this problem? Maybe you have social anxiety disorder. And then after a couple months, they changed the advertising. And they said, if you have this, see your doctor. And then later on, they changed it again. If you are struggling this way, you might have social anxiety disorder. See your doctor. Paxil might help. And see, America and New Zealand are the only 2 countries in the world that allow direct-to-consumer marketing by the drug companies. And the maker of Paxil actually developed a market for their drug, and they actually created a mental disorder through advertising. And they made social anxiety become a major phenomena, an epidemic all over, just through advertising. It doesn't always happen that way, but that's one way that this stuff happens. Okay, this was also in Psychiatric Times. I saw this when it came through. I said, hey, that's important to see. That's important to show people. Written in January of this year by Dr. John J. Miller, MD, in an article he published titled Discontinuing Medications, When, Why, and How. Now remember, this is on the Psychiatric Times, a pro-newsletter to psychiatrists, telling them how they should think and understand problems and work with problems. And here's what he's saying. 8 reasons to discontinue psych meds if you have an iatrogenic mental status change. In other words, iatrogenic means caused by the drug. If there's a severe negative mental change that's clearly caused by the drug, that warrants quitting it. Another is intolerable adverse effects, if they just can't stand the effects that are coming from the drug. Patient decides he or she no longer needs it. Change in financial or insurance status. Now, remember what I said earlier about it's the same as a diabetic needing insulin? Okay, if the person has a change in financial or insurance status, do they stop giving them insulin? No. Why? Because this is not the same as a diabetic. And this proves that it is not real as far as an illness goes, that you have to take the medication for the rest of your life. This proves that's not true. Onset of medication induced medical comorbidity. And again, I'll have to have a doctor's help on this one. I don't know all of my terms. But I thought it's important to show that they're telling their own people there are reasons why you should take your patients off. There are legitimate reasons. Onset of okay, I talked about that. Incarceration, surgery, recurrent abuse of a psych med. Conclusion: once a decision has been made by a competent patient to discontinue medication, even if you disagree with the patient's decision, a thoughtful and gradual tapering strategy should be designed based on the pharmacodynamic and the pharmacokinetic and the disorder-specific factors that exist. I think that's important to realize, because if there's someone who wants to come off and their doctor says you shouldn't because it's a lifelong disorder, you go on the website, onto internet, you go here, you get this, you take it to your doctor and you say, hey, there are legitimate reasons by your own profession telling you that it can be done. Dr. Peter Breggin, this is who I talked about some. I have a number of his books. And Mark and I went up to Michigan State, and we were at a 2.5-day conference earlier this spring that he put on. He's known as the conscience of psychiatry. He's a medical expert on many court cases involving iatrogenic, meaning the drug caused the problem, effects of psychoactive drugs. He was influential in bringing awareness to ECT and lobotomy. ECT is electric convulsive therapy. He actually was instrumental in getting our country to shut down almost all lobotomy. He was instrumental in that. He was also instrumental in getting they used to sell antidepressants, totally safe. He was in enough court cases and proved from the drug company's own records that they knew that antidepressants, SSRIs, potentially can cause people to commit crime, to commit murder, and to commit suicide. And he brought that evidence to the FDA, and he worked on them for many years until he got the FDA to force the drug companies that today the drug companies are required to put a black box with all antidepressants, SSRIs I believe it is, that they can cause suicide. And so they are so dangerous that they have to put a black box on. That's the potential. Here's some court cases that he was involved with. 2014 at $1.5 million, showing tardive dyskinesia in children. $700,000 tardive dyskinesia, 2014. $1.5 million for suicide involving antidepressants, 2012. They conclude Prozac caused teen to murder, based on his testimony. He medical expert, first ever psychosurgery malpractice trial. Breggin, medical expert, first ever electroshock malpractice trial. And here's one I'd like to point out. He is a medical expert. When the jury for the Supreme Court of New York awarded $1.5 million to a family of a man who committed suicide while taking psych meds. Everyone wants to say that when you don't take them, you commit suicide. But there's many suicides that happen when they're taking them or adjusting them or coming off quickly, and they're not teaching the people what the drugs actually do to the brain. Joanna Moncrief is another current psychiatrist, leading figure in the Critical Psychiatry Network, prominent critic of psychopharmacological model. I have some of her books. She developed this here observation. You have a disease-centered model or you have a drug-centered model. In the disease-centered, the drugs help correct an abnormal brain state. They help correct it. Drug-centered, drugs create an abnormal brain state. Disease-centered drugs are seen as disease treatments. Drug-centered psychiatric drugs are seen as psychoactive drugs. Disease-centered therapeutic effects of drugs are derived from their effects on an underlying disease process. Drug-centered, the therapeutic effects derive from the impact of the drug-induced state on behavioral and emotional problems. The paradigm is insulin for diabetes, and we already talked about that. The paradigm of a drug-centered model is alcohol for social anxiety. So, alcohol is a psychoactive drug. And one of the effects of that drug is to relax somebody. So you can look at that and you can say, I struggle, I have this panic attack, or I'm going to be really struggling with anxiety when I get into this big crowd of people. So I could take some alcohol, and the effect of that would relax me so that I wouldn't be all uptight. I can relax and I can respond more freely. This is the idea of how to look at psychoactive drugs. They all have an effect on the brain. And you need to look at, will the effect be beneficial to my problem or my struggle? Now, I would like to say that it should be as minimal as possible because it's actually affecting the brain. And Mark will probably share more about this. But what we have found is when someone is on even a moderate dose of any psychoactive drug, it will always drug them. It will dull their conscience. And when people say that it helps them to think more clearly, we have found that it's hard for them to get a hold of deep spiritual truths, or it's hard for the Holy Spirit to touch down into their heart and help them to see who they are. Peter Bregan, when he talks about people coming off of the drugs, he'll say that they become more aware, more of a clear mind, and they can reason. You can reason with them more clearly. How many people do you know that are on medications? You try to talk with them, and it's like you're talking to a brick wall. You just can't get through. Most people would look at that as it's part of the disease. What Peter Bregan says is the people coming off of medication, that stuff goes away, and they become more clear. I know of one person that I was working with. We went with the family to the psychiatrist. We said we'd like to help them get off. The person was functioning fine, but I could tell that they were under drug effect. When you talk, there's a little hesitation, there's a little slowness in the thought process. And we started working with the person. I told him, there was a problem in your heart before you start taking the drug. That problem is still there, and when we start coming off of the drug, you will start to realize that it's still there. You have to decide now that you're willing to deal with that issue when we get to that point, because it's not going to be fun and it's not going to be pretty. But you have to decide you're going to do that. They said yes. So we went with the family and went to the psychiatrist. Said, this is what we want to do. He checked with all of us. Everybody's agreed. So he said, okay, I'll work with you. So we started doing the taper with the psychiatrist's oversight. And he, partway through, the one medication was running out and they didn't want to renew it. They'll just quit. I said, I wouldn't. But they did. About 3 days later, they called and said, oh, this is happening, and I just feel this way. It's physical things. I said, well, I told you, go back on the last dosage and see if it goes away. And it did. And they called back and said, oh, this is so terrible, I can't think. When I was here just 3 days ago, I could think more clearly, and now I'm drugged. And the reason that they could see that is because they went back up, and it changed it back. Now, when you're going the other way, the change is like you putting a frog in the water and turning the heat up slowly. You don't realize that. It's so slow. But when you do this other, you see. And all of a sudden, they saw that. And I said, I told you it's going to be a major storm to try to get through. And they said, well, we want that. I want to think clearly. I got a glimpse of how that is, and so I want it. And so we continued to go. And all of a sudden, all this stuff started coming out. This anger and bitterness about a relationship. And just, oh, how terrible. And I kept saying, you remember what I said? That's still there. That's why you were put on the medication. All it did was mask it. Now you're seeing it. Are you willing to allow God to work in your heart in that area? There was a while I wasn't sure if they were going to see it. And I finally said, you're claiming to be a Christian. Are you willing to let go of that and give it to the Lord and forgive? And one of the family members was walking closely alongside of that person, and they saw it. And they were able to come alongside, just like Naaman's servants that said, if the Lord would ask you to do some great thing, wouldn't you do it? And they said, why don't you just trust God? Why don't you see what he's... And they went to the Lord, And finally, the Lord helped them to see that, and they surrendered and gave that to the Lord. And I talked to someone else later who had known this person a couple years before, and they saw them after this change took place, and they said, the person is just totally different, a completely different person. Now, that's not always the case, but that's what I'm trying to say as we look at these issues. Medical model versus social model. This is from a secular society. Brain malfunction versus faulty thought processes, biological or relational. You treat it with psychoactive drugs, which have negative iatrogenic effects, or you treat it with kindness, security, compassion, exercise, active dialogue, etc. Dr. Alan Francis says, for all moderate problems, you should always take a sugar pill because it is almost always more effective for all moderate problems, and there's no side effects for it except this. Argument supporting antipsychotics. You have the brain study on schizophrenia patients. They would say, okay, we have a set of twins. One has schizophrenia, one doesn't. So we're going to take brain scans. And the one who has schizophrenia has you can see changes between. You can see brain shrinkage. You can see lack of certain matter, and you can see lack of activity. Okay, so that proves. They're trying to prove from a biological model that it's a disease. What happened is, in every brain scan, they do not have a before and after scan of the same person. They're always comparing two different people. And it don't matter if it's twins. To have an objective measure, you have to have a before and after. I was watching a documentary on a researcher doing brain scans of murderers in prison. And he was showing, this is your range. Most murderers fit in this range. And he showed several different brain scans. And your serial killers, they're over here. And they said, now look at this one up here above the serial killers. He said, that one looks exactly the same. Now I said, don't get excited because that top one is mine. So what they're trying to do, they're trying desperately to find a biological link to prove disease. It's the same as the scientists are desperately trying to prove to find life in outer space. The same thing. It's all coming from an evolutionary basis about the study of man. The higher level of receptors, I already talked about that. Higher level of metabolites, and how this goes is when a drug goes through the brain, there's all kinds of neurons. It goes from one to the next, and when it's absorbed into the next neuron, it is absorbed as a protein, and it puts off metabolites as waste. That waste goes into the cerebral spinal fluid. So they determined that if there's excessive metabolites, dopaminergic metabolites in the cerebral spinal fluid of a schizophrenic, that would prove it's a disease. So they checked the schizophrenics, they checked the normal, and lo and behold, they had more metabolites. Proof! This is proof. Then they started thinking, but they were on antipsychotics. Okay, so now they checked ones who had schizophrenia who were not on antipsychotics and the normal people, and it was the same. So they concluded, in reality, the drug causes the problem. Brain shrinkage found with brain scans comparing earlier and later. Okay, so like I said, they don't have a before and after. And somewhere up here, I don't have it laid right out, I'll have to find it later. I have the actual research literature of a study they did with macaque monkeys. One of the drug companies wanted to put this to rest once and for all, so they did before brain scans on macaque monkeys, put them on antipsychotics for a while, and then did after brain scans. And it was proved complete positive. The drug causes brain shrinkage. And so now they don't talk about it anymore. The only thing they go by is the clinical effect. They come into the emergency room, they have this psychotic behavior, they put them on an antipsychotic, it knocks down the target symptom, they go home, and so it must work. The problem is they don't see that person in 6 months. Okay, so now we'll get into long-term outcome studies. Irving Kirsch, I don't have time to go into but he has studied all antidepressants, and he's been doing this study since 1998. He's looked at all the research. He's got the FDA records. And what he found was in their FDA records, they have all the research from the drug companies. But what they found was 40% of all research data on the common antidepressants was never published because it was negative. It actually showed that the placebo, the sugar pill, was almost as effective or more effective. To get a drug approved, you only need 2 positive trials with moderate, better difference than the sugar pill. And one of the drugs actually had 5 negative outcomes and 2 positive outcomes, and then they approved it because they have 2 good ones. And that's one of the common SSRIs. I forget which one. The chemical imbalance theory. He did this meta-analysis of all drug trial data. In drug trials, when they're going to approve it, they only do it for 6 to 8 weeks. That's all they do to determine whether a drug is safe and effective. When the trials are done for depression, it's always done on the severely depressed people. They tried it one time with moderately depressed people, and it was a complete mess because the sugar pill did way better. And so never again have they done research to approve antidepressants on anything other than severely depressed people. Now, in our plain churches, the majority of people on antidepressants do not fit the severely depressed status. And yet the trials show that the sugar pill is more effective. Now what he shows is, they have all the different kinds of things about the trials. All right, they've done all kinds of trials to try to check different things. They have head-to-head trials, meaning they take all kinds of different psychoactive drugs for depressed people. And what they've found in research is that it doesn't matter which drug they take, they basically have the same response rate. And what puts the nail on the coffin is that SSRIs are developed chemically with a theory that there's too little serotonin in the brain, and so they try to artificially force the brain or trick the brain into producing more serotonin, and that's supposed to help them get over depression. Happy pill. Just in the last couple years, France came out with a new drug, tianeptine, and it's an SSRE. It's a selective serotonin reuptake enhancer. So chemically, it works exactly opposite of an SSRI, and yet the response rate is almost exactly the same, within 1 or 2 percentage points. This is actually more effective than SSRI. So what he has concluded, and I don't have time to go into it now because time is almost up, but depression recovery by taking drugs, only 3% get better because of the therapeutic benefit of the chemical in the drug. All the rest this is his words. I listened to him give a lecture in December out in Missouri State University. All the rest are getting better because they're believing in it, is the ultimate thing. And he says if you have a culture that believes in alternative health, that means 97% of those people will recover from depression because they're believing in the alternative health method. And he said, if you have a group that's religious and believes in a God who heals, 97% of them will recover from their depression because of that faith. He said he's also more recently done research on the anti-anxiety medications. Same results. I don't have to go into all of it here. I don't have time to go into all that. Here's the brain scan, your ADHD, and your control subject. Normal, deprived murder, non-deprived. Schizophrenia, twin study. Neurotransmitters, here's how it works. Your serotonin goes out into the synaptic cleft, and it goes into the receptor. The SSRI blocks this reuptake inhibitor, so it can't go back in if it gets too much in here. That creates a buildup of serotonin, creating more in here, causing it to go through the receptors faster. Eventually, the brain says, wait, there's way too much serotonin going through the brain, so it starts shutting down some of these. This is a literal tissue change. It starts shutting down some of these transmitters. And it also starts to thicken and callous some of these receptors so they're not as receptive. To try to compensate that, this is that tissue change I was talking about, and that is literal brain damage. And that's why when you want to come off, you have to do it slowly so the brain can go run through the reverse effect of that. Robert Whitaker, a very well-known speaker and writer. I have a bunch of his books, a couple of them I should say. Here's long-term research studies. I don't have time to go through it all, but it's just study after study after study after study, they all show the same thing, that when you use drugs from a delayed approach or a minimal usage for a short time, the outcome is always better long term. And if you take drugs, it always, always, always causes a greater tendency to become chronic. So we're not saying you should never take, but to become familiarized with the problem, do your own research. We have literature here. As he said, we're going to be going through literature, giving recommended material for your own research. If you want, you can check the box. Thing about demonic. I'd like to say a little bit about that. Some people think about schizophrenia, all demonic. I don't have time to go through the spiritual arguments here. The biblical arguments. But I will say this. All long-term research has always showed that the greater percentage of schizophrenia patients recover within 2 to 5 years with minimal relapse. Most of them never relapse. If it's demonic and they're possessed by an evil spirit, they wouldn't recover and they wouldn't stay recovered. Also, the diagnosis. You can go to 12 different psychiatrists in different parts of the country. You'll get 12 different diagnoses. It's based more on the psychiatrist's view of life and nature of man and his philosophy, whether you get diagnosed with. I don't have time to go into all this, but all these different books support psychiatry. There's a new book that Rod and staff is actually trying to produce that is going to support psychiatry. We've asked them to stop, but so far they haven't agreed. You have NAMI, which is in the different of our circles. We are using their resources. Alternative health methods. I'll say a little bit about True Hope. True Hope was developed by a Mormon. He claims to have received the information by divine revelation through prayer and fasting, and he calls it True Hope. Only Christ is a true hope. That's very, very dangerous. Mormonism is considered an occult religion, demonic religion. Also, the main ingredient is B12, and the source of B12 they use is the kind that has traces of cyanide in it. And in order for the body to use it, it has to get rid of that cyanide. Dr. Morton in Pennsylvania says that it's wise to not use that source of B12 if you have to use it extreme dose or long term. Different care models that work. Is there still hope? Get back to God and His Word as the authority. Call church leaders to anoint with oil and pray. Daily walk with our Lord. Get back to handling problems of local bodies. Seek our source of wisdom, healing, and answers, God and His Word. When a need exceeds the ability, then call someone in who understands to help you figure out how to deal with it. Then you know how to deal with it in the future. Please don't send out unless absolutely necessary. And that's all. God bless you.